Get started? All right. Well, hello everyone. I'm Jason Lewis. I'm from Beth Israel Deaconess Medical Center in Boston. Together with Dr. Thomas, Dr. Evans, and Dr. Gittens, we're going to be speaking about administrative hygiene, what it is, and how to address it. The agenda for today, we're going to briefly discuss some background on administrative hygiene, professionalism in undergraduate and graduate medical education. We're then going to have 5 distinct cases addressing different issues of administrative hygiene and break out into smaller groups, although in this case we'll just be one group, to discuss strategies and experiences you may have had and kind of come back together to further discuss those strategies. So I'm happy you may all have your participation hats on. We'll then have some time at the end of the talk for just some more open discussion on any other experiences you might have had or experiences or strategies you've used in the past. None of the 4 of us have any conflicts of interest to disclose, so at this point I'm going to turn it over to Dr. Thomas for some more background information.
Okay. Pardon me as I try and navigate technology, which is always a challenge for me. But so is this working? I don't know if this is working. If it's not working, it's fine. I'll yell until we get it figured out. So one of the reasons that we wanted to talk about this is that, like, oftentimes many of us will have heard our sort of interns, our residents, people talk about, I just want to be a good doctor, saying that, in order to be a good doctor, in order to do my job well and to take care of patients well, in order to be a good doctor, I just need to come in, do good clinical care, and then leave. And then that seems to be the overarching sort of view of what we do as doctors. And so in that definition, actually, we all know that we wear a variety of hats in our everyday job, even if we're just community physicians and we have a full-time FTE clinically. We actually are not only physicians and clinicians providing clinical care, we're also subject matter experts. We end up doing a lot of teaching, sometimes just of our patients, sometimes of residents, PAs, advanced practice providers, medical students, et cetera. And then many of us also will have an additional hat, something like research, something like education, ultrasound, Sono Games is going on right now. But also, in this day and age, I was expecting maybe 2 more people to show up, but someone to challenge me on this statement that none of us are self-employed anymore. As emergency physicians, we do not work for ourselves. We work for someone else, whether that's a democratic group, whether that's another group that's run by a hospital, maybe it's a university. We always are employees of someone else. So all of us have administrative requirements that come with our jobs. Residents oftentimes like to think when we are in residency, like, all of these things will go away after I graduate and I'll just be able to do medicine and everything will be wonderful. Sorry. A lot of the things that we do in residency also kind of have direct corollaries in our employment. So things like duty hours submission can sort of closely correlate, sorry, clinical correlation, doctor, with timesheet submission, reporting moonlighting hours, procedure logs, and then CME and maintenance of certification. And you always have to attend something, right? Whether it's a staff meeting, whether it's didactics, there is a minimum requirement usually for attendance at some specific thing. So we're using this sort of branch term of administrative hygiene in the sense to say that there are certain things that you need to do in order to be palatable to other people. So there's kind of 3 buckets that these fall into. One of them is accomplishing required tasks. You have to do X by a certain date in order to accomplish this task. Another one is time-sensitive communication. This is kind of the stereotypical, you have to respond to emails within 24 to 48 hours. You have to kind of respond to people in a timely manner based on the urgency of their communication. And then there's this sort of larger bucket that's a little bit more difficult to define, but has to do with organizing yourself and your time to make sure that you are showing up for things that you need to show up for, and that you are managing your time appropriately to make sure that you can accomplish all the things that you need to accomplish. So, why do we care, right? Like, what's the big deal? Who cares if we get all of our stuff done? Who cares if we're really good employees? 2 different reasons. One is that increasingly over the last, I was gonna say 10, but I'm realizing more and more how old I am. Over the last probably 20 years, employers and residency directors, fellowship directors, everybody down the line is now asking previous medical schools, residency directors, et cetera, how does this person do administratively? Are they going to be a problem person for me? I can hire a lot of good doctors that can, that can do a lot of really good clinical care, but am I going to have to chase this person around in order to maintain their certification and turn in their licensure requirements, et cetera, et cetera? So why else do we care, other than being employable? It turns out that most of the issues that come up that really affect employability down the line. State licensure board censures, imprisonment, lawsuits. This all has to do highly with professionalism. So we read through all these things so that you don't have to. Some of them are a little bit dry, but the kind of seminal article in this field is by Papadakis, and that's kind of on that left-hand side of the screen. And really what it says is that they did this huge case control study where they looked at all of the graduates of these 3 medical schools across 3 different states over the last 20 years. And they said, how many of these people ended up being brought in front of their state boards for some sort of reprimand, right? And 94% of all of the physicians that came in front of the state boards for some sort of reprimand were for professionalism issues. They were not for necessarily clinical incompetence. They were not necessarily for, I made a big boo-boo during clinical practice and this has come back to bite me. It was usually somewhere in the realm of professionalism. Now, what do we mean by professionalism? If they break down a lot of these professional behaviors that people were brought in for, it turns out that the odds ratios of things like severe irresponsibility, if that is seen during your medical school career, the odds ratio on that is 8.6. You're 8.6 times more likely if you've been brought into a professional review board to have demonstrated irresponsibility during your medical school years. And then you see other things during residency. Residents who had been censured or had been brought in front of some kind of professional review board during their medical school careers were more likely to incur problems in residency, and were actually twice as likely to be sued afterwards in clinical practice. And this really, a lot of this has to do with irresponsibility oftentimes, those things like didn't show up, reliably to clinical practice, consistently late, didn't turn things in. It's just this kind of basic administrative hygiene that like any of us can do. It's just annoying, but we just have to do it. But those things, if they continue on to kind of snowball throughout people's careers, are the things that bring them in front of medical boards. It's not necessarily you're bad doctors and you don't know how to practice. It's you don't know how to manage yourself and your time. So with that, there's been a little bit of talk in the bottom left. Prasad was one of the people who looked at these things and said, well, we have to be really careful how we use this data, right? Like you can't just say that anybody who's ever been brought up for any kind of professionalism issue in medical school now needs a remediation plan for the rest of their lives, because the incidence of people actually being censured for professionalism things is quite small. 0.3 to 1% of practicing physicians will ever be brought in front of a medical board for any kind of censure or disciplinary reason. So the pretest probability of these things is very, very small. So we can't necessarily say everybody who ever has a professionalism issue during medical school needs to be like blatantly restricted from practice later on, but there are things that we notice during training that we need to target, and we need to take them seriously when we do see them. So we're going to now break up into our group. Thanks, Sono Games. We're going to break up into our groups. We can pick the topics. We have a couple of cases to go through. We can pick the topics that we're going to talk about for each case, discuss it, how we might address these things in practice when we see them in our trainees, and then just kind of come back as our group, our larger group, and discuss them a little bit. So feel free to share your worst, weirdest, and most wonderful instances of some of these things and how you've addressed them either effectively or very ineffectively in the past, because all of us have been there. All right. Yeah, it's fine.
Can they see me? Hi, everybody. I'm Ayesha. Oh boy. I'm a third-year resident at the University of Connecticut and also one of the chief residents. And the first case we're going to be discussing is around schedule requests. We initially broke this down into undergrad and postgraduate medical education. So the first case is approaching a clerkship, a student submits excessive and unreasonable schedule requests ahead of time, essentially dictating a schedule with unrealistic expectations. How do you approach this situation? How do you address this as a student's mentor? On the graduate medical education side, a particular resident perpetually does not submit any schedule requests by the deadline, and then last minute bombards the chiefs, admin, and schedulers to swap shifts due to scheduling conflicts. Who is the best person to have this discussion? And again, how do you approach this? And now we'll open to discussion within the group. About have you had this situation and how did you approach it, and what was your takeaway from those experiences? Pardon? Have you guys ever encountered this challenge?
Not yet. But I know that I will. Just from like the chief resident forum, I think there was a big emphasis on being sure that you're peer-to-peer with people and figuring out like what's the source of you not submitting scheduling requests by the deadline. Like, what's going on in your life? Do you need more reminders about the schedule? Like, it puts a little bit more stress on all of us, and kind of just leveling with the person and having a one-to-one conversation and not like all the chiefs with this one person. And yeah, I guess finding the source of why this person is behaving this way is like the most important part, I think.
Thank you. Over the last 1 year of experience, I have definitely learned that as well. We have another offer.
Yeah, so I think whenever you look at these types of things, it's kind of balancing like individual versus systems issues, right? Like you can't be fully functional if you're not a little bit like internally introspective as to why these things are happening, right? So like a lot of things can happen that are completely independent of systems and needs to be addressed on like an individual level. I look at the left-hand side, and I see like excessive and unreasonable schedule requests. So it's like to understand if it's excessive and unreasonable, what is the reasonable and non-excessive baseline for that, and is that defined to your students and your learners first, right? So it's like, if there's no guideline for what your requests are, how many days can you request off, how many weekends can you request off, can you not request off 48 hours in a row, like those types of things, like you can't always assume that they're making something unreasonable if they don't know what the expectations necessarily are. And I think a lot of the things that we do as like educators and in supervisory roles are like we just assume that people know. And if they do know and they do get those like these guidelines, or like you have a paper or like a like what do you want to say it, like a survival guide or whatever it is that basically like has these sets of information, then you could be like, okay, like just making sure you see this, you're aware of this is the expectation and this is like the guideline. Not to say we all need to like fall back on policy, but having that to like back up as like a basic standard of kind of care or standard of practice or expectation is important, because that you also then have some like hard information to go back on and be like, well, this is the expectation, this is where it states that this is the expectation. Hopefully we can do that further. What are the barriers then to this, and talk about it in a more personal, like holistic, supportive fashion.
Thank you. Any other discussion points? Thank you, Lauren.
So I completely agree. As previous clerkship director, it was amazing how many students maybe didn't realize that how this comes across. And a lot of these students have never really had a professional job at this point. And so I think we found that a little bit of that sitting down and having this professionalism talk, and this was turned into part of our orientation of a little bit about the professional expectations for the rotation and for the student. And I think overall it helped them for our rotation, but hopefully maybe impacted them for future rotations, so that we don't see this several rotations in a row. And I think that when you are the mentor and this is something that's occurring, it's really important to sit them down and make sure that they realize these expectations.
Does it make any difference if the resident is a wife and mother and has 3 kids?
I mean,
Oh, I think it was.
very loud. It absolutely does. And so a little bit of it comes down to kind of why these, again, why are these requests occurring? I think that at some point you do have to limit it, again, for the systems issue of you can't have certain students dictating the full schedule of maybe, we find in emergency medicine, maybe certain residents want only a day shift, but then some of our other students don't get to experience what a day is like in the emergency department compared to a mid or an overnight, which does have different a different feel. As a nocturnist, I can say a different feel than the other shifts. So I think it plays a part, but unfortunately it can't always completely still dictate the schedule from that standpoint.
What do you do when you have a repeat offender? So you've had this conversation as a peer, as a chief, as faculty, as a mentor, but yet every time, third, fourth time in a row, third block, fourth block in a row, you're having the same issue. Then what?
I feel like if it's a conversation that's happening multiple times and I've tried to address it with just you, maybe you need to hear something from somebody else, like a person of power, perhaps an APD or a PD. It will get through to the person and they'll realize that there are actual repercussions to unprofessional behavior.
As the person in charge of reviewing the faculty schedule, this still comes up. I think you have to be honest with them about the burden that they're putting on their peers, but it's also a good chance to reach out to the entire group and kind of address this issue as a whole. It may be that one particular time is more stressful, and that's why they're asking this for 3, 4, 5 months. Normally they wouldn't, and if you can get to the bottom of that directly talking to them, that's fine. If they can understand that it's really impacting everyone else's schedule by addressing it as a whole group, I think it can also be impactful.
Thank you. All right, well, do we have another point? Oh, I'm sorry.
That's okay. This might be taking it a little bit different, but I also think that like while face-to-face conversations are like very valuable, when you look at things that are especially like repeat instances, having some sort of paper trail for it is just as important. So like if it's a personal conversation, giving a summary to like if you're a chief resident or if you're an APD, like writing down the details of the conversation, summarizing it, giving it to your program director. Because I think when you look at this like longitudinally, and especially if these are issues that repeat or crop up over the course of years, then you need to put in more formal, whether they're improvement plans, whether it's remediation, whether it's like probation or things like that. It's really tough to go back and be like, well, we had this conversation maybe on May 17th. I have it in my Outlook calendar, but I don't fully remember what it said, as opposed to like, no, we have 20 different emails over 2 years that have discussed this, and it provides that data should it ever, be, like especially if we talk about like probation and things like that, people can appeal those types of things. So it really benefits the program and the institution to have that type of data to back it up too.
Yes, thank you.
And something that Dr. Evans had talked with me about yesterday is that now there is actually a slow box where they talk about your administrative strengths. Are you submitting things on time? Are you submitting too many schedule requests? Do you not show up on time for shifts? That sort of thing. So it's asked about. And I think we do a bad job of telling our residents how this is, and our trainees, I'm sort of coming from the GME side, but we do a bad job of telling people why this matters, right? It's like, you got to get this done, and we're like nagging people and pestering people because it's like, well, we have to meet this criteria for the ACGME, and we have to meet that, and like these are our bottom lines, but why does it matter to them? And this is really the reason why, right? We're not just trying to nag people to get our own numbers in. I mean, like that does matter to some degree, but the reason is like you could end up sued, right? You could end up negligent. You could end up in front of a medical board just because you never actually sort of learned and took the time to like do the things and form the habits that you need to have. And then you ended up being brought up in front of someone because you didn't answer 6 pages from a nurse that a patient was decompensating, because you never brought your pager to shift, because you never, sort of looked through the guidelines of your department. So if you're not keeping track of these administrative things and really recognizing as a trainee, like these have knock-on effects in my future professional life. My future employers are going to know that I'm not good at answering emails, right? Like my future employers are going to know that while I provide reasonable clinical care, then I'm not going to be an easy employee to have, and that I might actually end up sued down the line because my documentation sucks and I didn't say anything about it and I'm not responsive to this feedback. So there are knock-on issues that are very directly relevant to residents and to medical students that I don't think we actually talk to them about enough. And they hear, I need you to do this for my purposes. I need you to do this because it makes me look bad if you don't, rather than I need you to do this so that you don't run into problems down the line. And so framing it that way, I think, is probably the most important thing, because, like, you know, why do we care about professionalism, you know, quote unquote, otherwise? It's because it's the thing that gets you into trouble. Like, there is the occasional person who has sex with a medical student and ends up in front of the board because of that, but most people end up in front of the medical board because of neglectful things, and because of they're not completing things and doing the things that they need to do, that they know they have to do, they have the cognitive ability to do, but they're just not doing.
All right. I think we're going to move on to case 2.
Okay, so now let's move on to case 2. We're going to talk a little bit about inappropriate call-outs. And so the first case, again, we directed both UME and GME. So our first case is the UME case. A student emailed an attending less than an hour before a scheduled shift to say that they would be 2 hours late due to another meeting. When the student arrived to the shift, they made a blasé comment about knowing it would be fine because no one has to cover for students when they're absent. Does this point to any larger issues in your experience, and what's the best and the worst way that you've seen this handled previously? And then our second GME case is a resident frequently noted to stay 3 to 4 hours after their shift doing documentation. But then they call out of several shifts due to being too tired to work and needing time for wellness. Do you use a Jeopardy or a backup system, and do the residents have to find their own replacement? And then how do you address the tension between the need for wellness and the problems that can be created by this poor time management? And so I would say, why don't we talk a little bit about the GME side, since we kind of focused on maybe a little more the student side previously. Has anyone ever had situations like this? I see yes. I was going to say yes. That's okay.
There was a shift in the bar for how low, you know, we told people for 3 years, just call out with the sniffles, when before it was never an issue. And so trying to put the genie back in the bottle has been a thing. And then we swung way over to it's all about me and my wellness. This is emergency medicine. You were working 20 shifts out of 30 or 19 shifts out of 28. Like, I think the pendulum might have gone too far, and you look like the jerk when you're trying to just shift back towards professionalism. And so this resident that is unable to complete their documentation in time is telling you, I have a problem with professionalism. And then they have more wellness needs and more illness needs. This is the resident that might be a really okay doctor that I am not going to fill out paperwork for when it's time for them to get their job. All I say is, you are going to lose your job. I am sorry, you cannot show up on time, you call out inappropriately, and you don't get your documentation on time. You're a great doctor. We will not be providing you that excellent letter of recommendation that you're seeking. And all of a sudden it starts making sense like January of their 3rd year.
Thank you.
Sorry, I'm talking. I like to talk a lot. No, I as somebody who is in the GME like space, this is something that like our program is certainly like looking at as both a challenge and an opportunity right now. I mean, we do have a full Jeopardy schedule. I mean, full disclosure, University of Michigan, we have 64 residents in a 4-year program. So we do have both the like challenges of a lot of Jeopardy activations, but we also have the ability to have like a pretty like faceted Jeopardy call system, but it still got stretched a lot during COVID and kind of continues to. I mean, I think one part of this is the like documentation issue, which is again more of like a clinical thing, time management thing, which can get addressed in like both informal and formal ways. But I think the larger aspect is the second part of it, like how do you address the tension for wellness and like the culture that you then build by it or lose with it, and how it affects other individuals. And I think that's actually one of the biggest challenges that like fully bluntly like faces our institution, our program right now, is like everything that you do has like a webbing effect, but then you also need to balance like the individual wellness of one of your residents and an individual, and what they are going through, but also then like being able to have like confidentiality and protection for what is going on, right? Like, to some degree, like, is it mental health wellness needs? Is it illness? Is it short-term? Is it family bereavement leave? Things like that? Is it like social, like familial things, like life stresses? And to some degree, every individual needs like their own confidentiality with that. So it is really tough to be like, well, you're on a medical leave, but you're like posting things on Instagram right now. And that's challenging. I think by being able to like explain to the individuals like that this does affect other people, that you try and create a like culture of responsibility is extremely challenging, especially when you have people that come at things from like different backgrounds, different, you know, advantages, disadvantages, different levels. It is really tough, and I think that's what makes like a system great to have that type of like diversity, but it also like provides its inherent challenges. Using like Jeopardy backup system, like one of the things that we're specifically looking at for next year or enacting is like long-term versus short-term Jeopardy call. So by being able to have like extra coverage for medical leaves of absence is going to hopefully benefit us a lot, because then it takes like the short-term Jeopardy call as like, no, I woke up with a fever and I need to get tested for COVID or something like that. So.
Thank you.
2 points. The first one, going back to this specific scenario, is that this person is saying that they're unwell because they're staying late because they have poor time management. So going to the root of it, poor time management, well, why? Why is that an issue for you? Is it speed? Is it documentation? Is it procedures? Is it everything? What is the issue? Are you coming on time? Are you coming late, signing out late, and then trying to catch up because no, there's red on the board or people to be seen on the board? What is the issue? And maybe being able to have that peer-to-peer conversation, chief resident to senior or junior resident. And personally, it was difficult as a chief to have that conversation with a senior resident. Or does that conversation have to come from their faculty mentor? Trying to figure out, well, okay, why is there an issue and how can we address it? And if we address that root issue, then maybe we get you leaving closer to on time, and then maybe we get you not calling out as often and impacting everybody else. But I think the biggest challenge, or one of them, is definitely in, well, how do we actually help with the root problem?
I absolutely agree. We've had this issue with residents in the past where we've actually taken time out to have someone shadow and see if there's inefficiency on shift that is causing this. You'll find we've had very talkative residents in the past that like to talk on shift, like to kind of use their downtime between patients as a little bit of kind of that social aspect, and you have to have that conversation that getting your notes done and not staying after to, again, have more of that kind of social time, or spend time not doing your documentation, not doing your on-shift work. And sometimes we find it's easily fixable issues once you sit down and kind of address it root cause, like you say.
Obviously, Lauren and I kind of know some of the same people, but occasionally you'll find that this is actually a medical problem that you might not have anticipated that impacts learning. Whether it's an attention problem, something else that's cognitive, it may be the opening that this person needs. They really are having a problem with wellness, and it's beyond their understanding. And you can be someone who kind of talks to them, uncovers a little bit of that, and then maybe, you know, whether that's the APDs or the program director, it's for them to kind of provide additional resources for that person to reach out, either on their own or with the program support, to find ways to improve their performance that may impact them for their entire career. Frankly, we've seen some really struggling residents who look just like this go on to be just outstanding clinicians, and some of our best loved residents over time, even though we had this period where everyone was very frustrated and didn't understand why these things were happening. So.
That tells you that this is an underlying medical issue?
I'd say I'm not the expert, but some of it comes from those conversations you have. I mean, some of it's their attitude about it, what they're willing to disclose, the way you see them kind of interact with their work. People, sometimes it is having those people follow them around and do some sort of time observation studies that can reveal those clues, but I'm certainly not the expert in that.
Thank you. Does anyone else have something to add? Yes. Dr. Easton.
Yeah, so hi, Travis Easton. I'm from the University of Arkansas. I was Lauren's residency director, so I also know some of the people that she's talking about. I think the GME scenario is really complicated because it potentially includes like 6 or 7 different underlying issues. Like, one of the things that we have done is when we get residents that have this kind of time management issue, we pretty much uniformly refer them for neurocognitive testing. Do they have ADHD? Do they have dyslexia? Do they have some other underlying problem that they're such high performers that their entire life they've been able to compensate, and now they've hit the point where it's just too much and they can't do it. And we've definitely had residents who have resisted that. And we've had some residents who have gone through it and people are like, no, you're fine. You've got some other issue, but it's not this. And so, the other thing, if you take out kind of the stay 3 or 4 hours late, but it's a lot of call outs, like Greg said, is there a medical thing? Is it mental health? Is it substance abuse? We've had those scenarios as well. And the interesting thing about the people who are just like late to shifts, that can go on for a while before anybody figures it out, because the nature of our schedule is that it's not the same people that are there when they're late, right? And so until it's happened to the same people a couple times, it can be really tough even to notice it, because people, sort of human nature is you're kind of like, oh, like it's just, everybody's late sometimes, and nobody realizes that like this person's been late sometimes, a lot of times. And so, yeah, I think there's a lot of different angles to this. The neurocognitive testing has been a good thing for us. We've been lucky; our DIOs have been psychiatrists, so we can kind of like bounce things off them. And then, as far as like the like medical and mental health things, one of the things that our DIO told me very early in my program directorship was that like you're their boss, not their doctor. And so, like resisting the urge to diagnose them or even worse, treat them. Obviously you can't turn off the fact that you're a physician. You're going to have suspicions, and that's where you need to make sure you're referring them appropriately. So yeah, a lot of potential issues here. As far as jeopardy, we don't have one because our residents have always resisted it. And so the agreement that we have with the residents is that we will not have jeopardy until they are not able to fill the shifts that need to be filled. And once that happens, then we have a jeopardy system.
Thank you. Okay, I think we're ready to go ahead and move on to case 3. I'm going to hand off to Dr. Lewis.
Again, thank you everyone for your participation in this small group, so we really appreciate it. So this is a more of a choose your own adventure, not really GME versus UME, but kind of two different issues. But one is, how do you respond to the trainee who consistently fails to submit administrative tasks on time? For example, duty hours, their online learning modules, any required ACGME surveys, or how do you approach the trainee whose lack of timely response to emails is starting to cause significant issues?
To start this off, I think, and there's at least one person in here who can correct me if I'm wrong, but I think that we do this poorly, and we just kind of end up just nagging people on individual instances, right? Like you didn't submit your duty hours, you need to submit your duty hours. You didn't submit your duty hours, your conference attendance is below, and there's just sort of like individual reminders, and that ends up, I think, creating a lot of friction between the residency leadership or the administrative staff and the person in question who is getting nagged. There's kind of a lack of, we hear a lot of, you're treating me like a child, you're nagging me, you're not treating me like an adult learner, you're not respecting me, and, you know, sort of like, why do you keep bugging me about this? And recently we kind of swapped from checking things quarterly to checking things monthly, for example, like conference attendance and duty hours and that sort of thing. And there's been a lot of resistance to that as far as like, why are you nagging me? Why are you nagging me? Why are you checking this monthly now? And so I would be really interested to hear if anybody does this better, that we could pick up tips from, because we have not necessarily found a really effective approach.
This kind of goes back to the same issue of professionalism that we saw before, but one thing we did was to really empower our coordinators to poke us when somebody is consistently on that list. You know, after 3 emails, the coordinator sends the names to myself or the PD, and we tiger text them with priority text. And then it's a conversation later in my office about, you need to stay off of the list, right? These are things that are mandated by people with more stake than you will ever realize. If you don't want to get paid, don't put in your duty hours. It's not that easy. You will hold up the whole process for 700 people getting paid if you get too behind on these things. The same thing with the modules, the ACGME survey. We figured out ways to have loop back to make sure that they're being done while trying to keep the anonymous stuff. Some of the other things, we've gone the other way, unfortunately. So when people weren't doing their learning modules, we now have added that in order to progress to second year, you need to have completed those modules the first year and done them in a timely manner. And we hate to be reactionary and punitive, and you always try the carrot before you try the stick. When things aren't working, you just have to gather. The other thing we do is engage our chiefs. What do you think we can do to help people be grown-ups, right? What do you think we can do? Because sometimes there's something out there in the strata that we are unaware of, or we will change something on a platform and not realize that instead of 10 clicks to do it, it now is 42 clicks, and it's much more time onerous than what we realize since we are not doing those things. So engaging your coordinators to kick things up the chain, having meetings with people when they are falling behind professionalism. We love problems that have to do with medical knowledge. We can fix those all day long, right? The problems that we have that will manifest later on down the road are always professionalism issues. And so these are the things we talk about. You have to keep your license up. You have to keep your DEA number. So it's easy to draw that extrapolation once you get them in your office. So empowering your coordinators, your chiefs, sitting down with them to say what this means, and then talking about some of the things that unfortunately now negatively impact the entire residency because you 3 or 4 couldn't get it together. Sometimes has a little bit more, but some people don't care. And some people you have to look for a different reason just to figure out why. And sometimes that's on us.
Yes, thank you. That was excellent. We do similar. We have our educational executive committee every month that these issues are brought up and are addressed kind of in real time with our APDs emailing out. That's kind of our strategy to get at least trying to figure out the bottom. But it really is speaking with the person individually, understanding where the lapses are, but explaining why these things are important. I think, as residents and trainees, you see these tasks, you don't necessarily think about them as important to everyone else in holding up the group, but just explaining how these impact your job going forward and your recommendations going forward is essential. Has anyone else had any experiences?
Hi, everybody. My name is Mary Haas. I am also from the University of Michigan, like the lovely Dr. Thomas. And I know Dr. Thomas is actually engaged in a really innovative effort called the Intern Development Group, where she's been meeting on a recurrent basis with our interns. And I think there is some specific teaching around professionalism when it comes to communication. And I've found that to be like one good approach, having kind of not quite a peer resident doing this teaching, but somebody who is like a more junior faculty in an APD role, where there's that like psychological safety to kind of do some coaching around the basics of professionalism. And then I do remember an experience. We had a trainee who really classically struggled with inbox management, and she was an excellent resident, excellent human, but this really did become an issue for her. And part of the problem was that her inbox was so full that it was like so overwhelming to her that she could never catch up. So our program director had to do some specific coaching with her, and ultimately like sat down with her and had her just delete her whole inbox and start from scratch. And just like that totally revolutionized her approach. And once she could like start from scratch, she could finally keep up again. And that was a really powerful moment for her. And from then on forward, she, did a lot better with email management. So sometimes I think it is a matter of actually just like starting from scratch.
Clean slates can definitely help in some of these instances.
The last thing that I'll add is we found some of our trainees also have issues with email as well, and the email inbox. And sometimes we can have our coordinator send a text and we get an immediate response of the ACGME survey gets completed. And it's not feasible with a large group, obviously. It's not feasible with a large residency, but sometimes in the interim, while working with residents who struggle with some of these issues, we found that giving them that reply so that they aren't constantly on that list can help them as well.
The only other thing I would add is that you also have to give them time. So we block out that morning before conference. So they're going to get up at 9. So they're sleeping 2 hours, 3 hours later than they would for a shift, and they don't have to be at conference until 11. You are giving them the time to actually make sure you're not taking away from their weekends and their evenings to do the things that need to be done. And that's on us again to make sure we're not overbearing them with the things that we want them to do.
Yes, thank you. Okay, we're going to move on to case 4.
Tardiness. A student always seems to be late to required non-clinical activities, including group didactics, simulations, and journal club. Often the whole group has to wait until they get there to begin. How do you as the clerkship director address this with the student? Or how do you as the supervising resident or supervising attendant of the specific event address this in real time? On the GME side, a resident always seems to breeze in at or slightly after the start of a clinical shift, delaying sign out until they can get set up, signed in, and ready to proceed. As the chief resident, how do you address this? As the co-resident, how do you address this? And as leadership, how do we address this?
Hi, I'm Emily. I'm one of the chief residents at UConn with Ayesha. So I think it starts with the chiefs before escalating it to like leadership, because I think there's more of a level of trust between the other residents and less like you're scolding them because it's coming from a co-resident. I usually start the conversation with, hey, we've noticed that you've been coming late to shift, and like one off time I don't think is a problem, but if it becomes a pattern, what's going on? Is like there's something that's preventing you from getting to your shift on time? Like, are you having car troubles? Are you having family issues? Like, is there something that can be addressed that's not just you not caring about coming to work? So I think having an open conversation about, is there something that we can do to help or leadership can help to get you to your shift on time? And if there isn't a good excuse, or you make the efforts to help them and it continues to happen, then it needs to escalate above to, the mom and dads of the residency to deal with it because it's out of our hands.
Thank you. It's always interesting as a co-resident and not as a chief resident, so being in second year and kind of your fellow second year coming late and you're like, what's going on? Everything okay? But I found it was a bit more difficult to have it not as a chief resident, where you couldn't quite scold them for being late, but you wanted to have that conversation. What about with students?
This is a characteristic. I talk too much, so I apologize. I think a lot of this goes back to what's the big deal, right? Like everybody says, what's the big deal? I was there a couple minutes late. Like, why is this a big issue? And one of the things that comes out of the literature search, which we did, so you don't have to, very dry articles, is that a lot of these attendance issues become a concern, right? Like it's this repeated pattern of just a little bit late, just a little bit unreliable, just once in a while doesn't show up, not really a reliable kind of like organized person. That is the number one thing that is associated with being sued and with being censured or brought in front of a state medical board is irresponsibility. It's not, again, I hate returning to this, but this is one of the things that I think we don't communicate with people, again, is it's not clinical incompetence. It's not like a knowledge gap, and it's not the things that we usually teach during residency. And a lot of people will say, well, why can't you just let me be an adult? Like, these are the things that are associated with actually big ramifications to your career. So the big deal, I think we need to do a better job, whether that's, as a chief resident or as a program director, we can actually point to literature about these things. And I don't think that oftentimes we think that we can because they're soft skills, but we can really point to numbers and say, you are 8 times more likely to be in front of a board if you continue with this pattern. People who have done the same things as you have are 8 times more likely to go in front of a medical board. You don't want to get sued. Being sued is terrible. We all know that. And you don't want to necessarily be brought up, even in residency, being brought up in front of your program director and not being recommended for a job, big deal, right? Like you have to get a letter of recommendation from your program director for your next job, whether that's fellowship, whether that's your next employer, and they do not have to say, this resident is great, wonderful, and perfect. They will be asked, like, how are they administratively? Not great. They have to say that. That's their responsibility. So, like, it is, I think a lot of times, what's the big deal turns into we have to actually say what the big deal is, right? Like, we have to communicate that with people. And oftentimes, I don't think that we think we have the tools to do so, but we actually do.
Awesome. Thank you. I think I'm going to hand.
Yeah, I think that we've kind of reached our time. We had one more case, but we've kind of reached time, and we really thank everyone for the great discussion and great input of the different cases that we brought forward, because we know that this is, again, something that programs across the country struggle with, both from the GME side and the UME side. So it's great to start these discussions of how different places handle it, and potentially come up with some best practices that can help other programs and help others who are in a similar situation. So thank you so much for the great discussion, and thank you for joining us this busy sauna game morning. We appreciate it.